My name is Sarai Tufala, and I'm a doctorate student in the Faculty of Health Science and Environmental Sciences, and my supervisor's up there, and so is my title as well, and it's Specific Mental Health. My main reason to give this presentation, my main reason to give this presentation is that I just want to disseminate my research findings. And this is the first time, even though there's only 3 audiences here, first time I'm going to convey my research findings. I feel that my research is significant, and it's a contribution to Pacific mental health because there were a couple of recommendations by New Zealand commentators, for example, for urgent research into problem of Pacific mental health consumers and their families. There's no research into their perceptions of the use of mental health services. Also, there's some criticism about the GP's referrals for Māori and Pacific people are minimal, yet the court referrals and other forced referrals for these groups are quite high. Also, the methodology that I used is based on the qualitative descriptive research methodology, which is based on the interpretive paradigm. Data collections, focus groups, and semi-structured interviews that I conducted. I also used the Tuvaluan research framework, Te Pā, which I developed in 2011, which describes the research processes and in a metaphorically way, accompanied by relevant Tuvaluan principles, customs, and traditions. The sample are Tuvaluan descent, separated into 4 groups. These are the 4 groups that I researched: mental health professionals, mental health consumers, and relatives and community representatives. The main reason for my presentation today is to disseminate the findings, so I'll be discussing that later. Hopefully, if I have time, I'll do the limitations as well. Before I disseminate I convey my research findings, I just want to explain the model that I used to organize my findings. And the one that I used was the pathway to the utilization of mental health services, which is a process of stages, and these are the stages of it. And it's first one is symptom identification, evaluation, and then the second one is the help-seeking stage, and the final stage is the use of mental health services. Each of these stages also have barrier factors. Okay, what are my research findings? First of all, what I found is that apathy was a strong finding that I located in the Pacific Perceptions, and and I found that apathy was the main finding that I found. And when we're discussing, in this particular one here is stage 1, which is the problem of identification. There were only 2 stages in the whole pathway process that I came across that the participants spoke about, and there was the stage, symptom identification, and the help seeking. So what was the problem of symptom identification of mental health psychotic episode? And one of the most important finding that I found was apathy. And apathy, what I mean by apathy, there was lack of knowledge. Implicit and explicit evidence of it was conveyed by the participants. The other one that I also located was the homeland influences, and this was not found in any of the literature that I read. They did not discuss anything about what we used to do back in the islands, and I'm talking about international as well as New Zealand literature as well. So this was an unexpected finding and a great contribution to New Zealand as well as international literature. And one of the homeland influences that the participants spoke about is that the behaviors of the practices, the attitudes and the behaviors in the islands were continued here to New Zealand as well. And this also involved the utilization of mental health services. And they said, oh yeah, we know why we're not using mental health services. Simple, because back in the islands, we don't seek mental health services. And I would ask them why. Because firstly, there are no mental health services there. And because of that, there are no specialists as well. Secondly, they regard mental illness and intellectually handicapped as similar. They identified as two similar groups. And they use this term called valia, which means crazy, stupid, for both groups, even though they're different. There's also, they say that there's spiritual diagnosis. There's no such thing as mental illness in the island. And when I say spiritual diagnosis, I'm talking about religious, supernatural, or ancestral curses, which, any of the other minority groups will use for anything that's unexplained. Also, shame, stigmatization is so strong in the island. So all these attitudes and behaviors continue to here in New Zealand. And the consequences of not being able to identify the symptoms of mental illness, obviously, is inaction. They don't do anything about it, or they delay help seeking. Symptoms, and what happens is that symptoms worsens, and sometimes police are called. Okay. The other thing that they spoke a lot about is the stage 2, which is help seeking. And what was found is that there's a delay and absence of help seeking behavior. The participants acknowledged that Pacific people normally do not seek mental health services, but they also gave reasons for lack of help seeking behaviors. They know the answers themselves. And one of the main reasons they said was, again, apathy. They said that they don't understand, they don't know anything about treatment, they don't know where the location of the mental health services are, they don't know the types, and they don't know how to access mental health services. Secondly, again, there's also this unexpected major theme that was located, and that is the influence of homeland beliefs and treatment practices by migrants. And this is a stronghold in Pacific perceptions of why they don't use mental health services here in New Zealand. According to them, it continues from the islands. The thinking of how the people believe in the islands continue to here in New Zealand, and that's just the migrant groups. So I put this down here. There's a lot of findings. I'm just trying to summarize my findings here, and one of them is that was very visible. What's the difference between the New Zealand born and young? I've been speaking about the migrants' perceptions. This one is the New Zealand born and young. Very difficult when I was doing my research because they don't speak. And that's typical of Pacific Island cultural protocols when they have meetings and things like that. When there's elders there, they don't talk, the young people. And when I tried to ask them some reasons of what they think, and there was a lot of apathy there. They didn't understand anything about mental health. You wonder why they don't turn up they don't seek mental health services. And so inexperience is one of the main factors when you're dealing with New Zealand born and young, and they're young. The literature though stated a lot of other barriers, and which I did not find when I was doing my research. So that's why I really think that my research findings will contribute a lot to the international as well as New Zealand research into minority studies regarding mental health utilization services. And but there were a few, and one of them is a lot of them spoke about the inadequacies of primary mental health services, which is the general practitioners services, and this is found in a lot of international services, research, as well as New Zealand. And 2 GP participants spoke about the lack of training that they have in mental health. They're not trained in mental health, so they're regarded as gatekeeping systems for further treatment. And they're saying one of the other reasons why they're described as gatekeepers is because they don't have sufficient consultation time to, for mental health patients. For example, 15 minutes are usual for consultation time for general practitioners, but when you're dealing with mentally ill people, you need at least an hour to assess them. Also financially expensive, that's also in the international literature. And a few of my participants, not many, spoke about it as well. Cultural incompetency of staff, that was spoken about, but not that much as I would have expected. Immigration GPs also spoke about the immigration problems. And they don't have residentials or citizenship status, so they don't have any, they're not eligible for funding, to seek treatment. One or few spoke about, even if they know how to access mental health services, for example, crisis mental health services, there's difficulty in the criteria for any of the crisis units to intervene, which is the harm to oneself or to others. That's the only time they will intervene. Otherwise, you can call the police when something bad happens. So, what are the implications? I'm going to go through this really fast. Obviously, police intervention, crisis mental health services are involved, acute hospitalizations, which are inpatients, forensic and suicide. And this is only when you don't use mental health services, not, the normal process as I spoke about it before. It's not, this is the implications of under-utilizations. Perceptions or solutions, my participants also came up. I didn't ask them, they just came up themselves with the solutions, and many of them spoke about educational programs, advertisements, only about what to do when something happens. This is what, and the importance of, attending, utilizing mental health services to avoid these sort of adverse consequences. And they don't really want to know much about the treatments and all the other aspects of mental illness. They just want to know what to do if something happens. And Pacific learning styles, they're saying it's really important to consider Pacific learning styles as well. Okay, New Zealand born versus migrants are also it's very important. We're just talking about educational programs. You need to consider the New Zealand born and migrants learning styles are completely different. The age groups are also different when when you're initiating these educational programs. Limitations. I'm going to speak about limitations. First of all, it's a taboo topic, so I found it really difficult to do my research in this particular with the Tuvaluan Pacific people, and because of that, no community consultation occurred, because they don't want to discuss anything to do with mental illness. Also, underestimated the shame aspect was really difficult. I didn't know that it was going to be that bad. So recruitment of my participants was really difficult. I underestimated the influence, the impact. So there were smaller numbers of participants as expected. Sampling, yep. And because it's a small population, Tuvaluans in New Zealand, I'm Tuvaluan by the way, there's only 3,000 of us. I underestimated the mental health professionals of my people. There were only 3, I needed 6. And obviously mental health consumers, I found 1, and then later on 2. It was supposed to be 6. I underestimated that as well. So there's a lot of underestimation that I did, and I won't do that again, or some other Pacific researchers won't do that again. So that's the main limitation that that I came across. Yeah. Oh. Thank you. Yeah.
First, thank you very much for doing this. No worries. So I'm sure the next presentation you're going to have will be I was just interested to use the term empathy because that's quite a negative connotation, but then your reasons underneath were actually lack of information and maybe incorrect knowledge about what causes mental health illness. And I just wondered why you chose apathy, because it sounds like you can't be bothered rather than suggestions were that it was because of other reasons. I misunderstood.
Yeah, I used I used the word apathy. Me and my colleagues did, and the reason for that because it was apathy, and the apathy can incorporate a lot of other meanings into, and all those we found, that it was apathy. This disinterest, ignorance, all the other, and that's sort of encompassed. Apathy was the best word to use. You can use lack of knowledge, but then you have to specify this and that and that. So, yeah, and a lot of it has to do with disinterest as well. There's other. It's really amazing what I found. A lot of other factors that I found, but I had to summarize it. So, and that's the reason why I missed a lot. But yeah, it's very interesting. But many of the literature that I came across, it did not have homeland influences. And that was very unexpected, and that's why I'm so excited about it. I don't know why they didn't have it there, because I think it's just because it's obvious. Obviously they're migrants, they must have got it from, but they did not specify that. But in my study, it's specified. Yeah.
Thank you for what you've shared. Could you talk a little bit about your experience of designing your program, the output?
Well, I was told, encouraged to follow the Talanoa method by Violetti. He's a professor at Waikato University, but I thought I'm not Tongan, I'm not Tongan, so, and I don't really understand that it's called Talanoa, where it's a bit like focus group or some meeting, this conversation, I think, something like that. So I thought, no, that's not me. I'm Tuvaluan, so I can't develop my own. And all it is metaphorically is the research process, and I just changed it to Tuvaluan for the Tuvaluans to understand, incorporating all the customs and traditions of Tuvaluans. So it's only for researching Tuvaluans and Tuvaluan issues. Yeah.
Will you now go back once this is finished to your people and share what you...
Yeah, it's part of the ethics. When you apply for ethics, you have to do that. Yeah. Thank you.
Now, so next event can start. Well, thank you on behalf of University Post Center. Thank you for your presentation.
Thank you.